Hello, let's us continue with our session on how to interpret microbiology reports. So we have learned about the MICs and the breakpoints. Let us proceed to epidemiological cutoff value. Epidemiological cutoff value is also abbreviated as ECV or ECOV. They are the measures for drug MIC distribution that separate the MIC distributions of the bacterial population into those with wild type and those with non-wild type. What do we understand by wild type? Wild type are those bacterial populations of MICs which has no resistance mechanisms, while non-wild type has inherited resistance mechanisms. For example, when you plot the MICs of the bacterial population, the lowest MICs has no resistance mechanisms and they come under the wild type, wherein we have cutoff. The MIC is less than the cutoff is considered under wild type and it has no resistance mechanism. But the MS is more than the epidemiological cutoff is taken as non-wild type, it has resistance mechanisms. So epidemiological cutoff help us to understand only with the that is whether the bacterial population is wild type or non-wild type, that is whether they have a resistance mechanism or non-resistance mechanisms. So here you can see we have an epidemiological cutoff value. The epidemiological cutoff value is much lesser than the CLSI breakpoint and the UCAST breakpoint. And when the MIC is less than the epidemiological cutoff value, that means they don't have a resistance mechanism as well as they are sensitive as per the breakpoints of CLS and UCAST. We have softwares wherein we can use the softwares wherein MICs are entered and we get the epidemiological cutoff values as well as the breakpoints. Now, what is the guideline for interpretation of the ECOF values? When you plot the disc diameters, the zone of clearing of the antibiotic disc, then uh, the zone of clearing which is the highest, then more than the epidemiological cutoff value is taken as a wild type. That is, they don't have a resistance mechanism. While the zone of clearing which is less than the epidemiological cutoff is taken as a non-wild type. That is, they have some resistance mechanism. The MICs wherein the epidemiological cutoff, where the MIC is less than the epidemiological cutoff value was taken as a wild type. So when take the example of azithromycin against Shigella flexneri, when the MS is say it is 4 and while the wild type ECOF is 8, so the 4 MS is taken as a wild type. That is, it has no resistance mechanism. If the MS would have been 32, which is more than the non-wild type ECOF point, then it will be termed as non-wild type, and that is has some resistance mechanism. So it depends upon the epidemiological cutoff that we can you can interpret whether the bacterial population has a resistance mechanism or no resistance mechanism. Similarly, for example, Candida lucida, the MS is 2, while the ECOF is 1. So since the MS is more than the ECOF value, it belongs to a non-wild type. That means it has some resistance mechanism. Now, the agent in question is being used for treatment, and the patient should undergo clinical review. And in consultant with the addition physician or pharmacist, the decision should be made whether to continue the treatment or not. So, what is the guidance tells us about ECOF? That when they should not be used when breakpoints have been published. Only in the absence of breakpoints, the ECOF should be used because they are just a predictor of resistance mechanism. They cannot predict whether there is sensitive, intermediate, or resistance mechanism. So therefore, they need to make certain that labs do not report the ECOF values. Otherwise, the patients may be harmed. Now, what is culture and sensitivity report tells us? It tells us about the identification of bacteria or fungi. It tells us about the sensitivity results, but it doesn't tell us whether there is infection or contamination or colonization. So it does not tell us which antibiotic to use. So it all depends on the interpretation. Also, it needs to be borne in mind that sensitivity testing is an in vitro phenomena, and it does not necessarily reflect the in vivo efficacy. Susceptibility testing is subject to great variability depending upon the testing in the labs, with which type of pathogen is being tested, which media is being used, the conditions of incubation, and the method of assessing the bacterial growth. What about the critical alerts that we get? Say for growth of pathogen from a critical sample like blood or CSF needs to be immediately informed to the clinicians. Any resistance mechanism such as MRSA, ESBL, CRE, VRE needs to be immediately informed to the clinicians for the immediate necessary measures such as transmission-based precautions and immediate empirical therapy. Not all the antibiotics could be reported under microbiology report. We report only the representative antibiotic of that group. For example, erythromycin is susceptible to azithromycin and clarithromycin. So only erythromycin is being reported in the microbiology report, and the results is extra reported to azithromycin as well as clarithromycin. Similarly, if oxygen is resistant, it's pretty resistance to beta-glutamine group of antibiotics such as penicillin, cephalosporin, carbapenems, and monobactams. It also needs to be borne in mind that some of the organisms has intrinsic or natural resistance against antibiotics. For example, enterococci, which is the most common hospital-acquired infection, has natural resistance against most commonly prescribed antibiotics such as cephalosporins, aminoglycosides, and lymphocytes. Similarly, Klebsiella is intrinsic resistance against ampicillin. Pseudomonas is intrinsic resistance against tetracyclines and first and second generation cephalosporins. And there are many such examples of bacteria which has natural resistance against antibiotics. So this natural resistance or intrinsic resistance needs to be borne in mind while doing the empirical therapy. Also needs to be borne in mind that there are some antibiotics are time dependent antibiotics, some are concentration dependent antibiotics, and some are AUC by MIC dependent antibiotics. Time dependent antibiotics require frequent administration of antibiotic that extended infusions and bolus dose. While the concentration dependent antibiotics requires only higher doses, that is once a daily dosing. For example, time dependent antibiotics include beta-lactam antibiotics, carbapenems, lymphocytes, while concentration dependent antibiotics examples include aminoglycosides. We also have hydrophilic antibiotics, which has poor intracellular penetration, while lipophilic antibiotics have it's good intracellular penetration. Diffusion of the blood depends upon the volume of distribution and the creatinine clearance. In sepsis, there needs to be high loading dose and increased frequency. In case of lung infections, the penetration is low for carbapenems. That is a lung epithelial barrier penetration is low for carbapenems when compared to beta lactams. Hence, beta lactams of fluorochlorophenol needs to be administered. And so for soft tissues, lipophilic drugs are accumulated in the fat. They have suboptimal concentration. What not to give in blood is tigecycline in CSF, first and second generation cephalosporins, gestafamycin, colistins, oral agents, needs not to be given in CSF. So this needs to be borne in mind. Even in abscesses, aminoglycosides needs not to be given. And there are this chart is this table lists about the oral bioavailability against different antibiotics. Inazolid has 100% oral bioavailability, while cotrimoxazole has 90 to 100%. Oroconazole has 96%. So 100% bioavailability does not imply 100% serum concentration. What the important PK matters, pharmacokinetic matters, protein binding and hydrophilic nature or lipophilic nature. Protein binding, that is a high protein bound, for example, ertapenem is given on outpatient settings. So there is a slow release, slow elimination, example ceftriaxone. While hydrophilic and lipophilic antibiotics are like hydrophilic antibiotics like underexposure beta lactams or vancomycin or aminoglycosides are given in sepsis. So the pharmacodynamics needs to be considered while doing the empirical therapy. What happens if you increase the dosing interval? What happens if you increase the dosage? All depends upon the pharmacokinetics and pharmacodynamics of the concentration about the window. Now, for example, about the MICs, there is another area called as a mutant selection window, mutant prevention concentration or mutant selection window, wherein if the concentration of antibiotic in the serum is kept much higher than the MICs much higher above the MPC, then there are lesser chances of selections of sublethal or of bacterial population with some resistance mechanisms. Persistent suppression of the bacterial growth following antibiotic exposure depends upon the nature of the pattern of the activity, whether the concentration dependent antibiotics or time dependent antibiotics or AUC by MIC dependent antibiotics. For example, aminoglycoside, as said before, maximize the concentration. For beta-lactam antibiotics, maximize the duration. For adjuvant macrolides, maximize the amount of the drug. Find the PKPD index is very important in vitro because it will reflect according to the in vivo concentration antibiotics greater rate and extent of bacterial killing. Pharmacodynamic goal is to maximize the concentration. For example, aminoglycosides they play the concentration dependent killing. Then, as you can see from the chart, the higher the concentration, once a daily dosing maintains ensures that there is the efficacy of the antibiotic is mentioned. Then we can adopt the Hartford normogram, which utilizes the high amino acid doses and extended once daily doses. It is proposed and implemented by Hartford Hospital in Connecticut. Another example of concentrated antibodies is fluoroquinolones, wherein we have a ratio of AUC by MIC, which can help us in understanding the dosage for the empirical therapy or therapeutic considerations. Regarding the beta-lactam antibodies, maximize the duration. For example, more than 60 to 70% of the duration is required for cephalosporins, more than 50% for penicillins, more than 40% for carbapenems. So the objective should be to maximize the duration of the beta-lactams in the serum because it's being a time-dependent antibiotics. Similarly, peptides with the beta-lactam antibiotic, more the duration of the antibiotic in the serum, the more efficacy of the antibiotic. There is a post-antibiotic effect, that is a persistence of the bacteriocytic or bacterial activity after the drug concentration at the target site. It depends upon the nature of the antibiotic, whether it's time dependent or concentrated. How to use the MICs if the organism is reported sensitive, regular dose. If the organism is given intermediate, higher dose is required for longer duration or shortest doses is interval. If the organism is given resistance, more likely it won't be responding. Fewer drugs are reported as susceptible dose dependent. There is also higher doses will be required depending upon the nature of the antibiotic. For beta-lactam antibiotics or time-dependent antibiotics, extended infusions or continuous infusions or because they are maximum duration, because there is no advantage of increasing the concentration. Post-antibiotic effect in this group of antibiotics is negligible. It requires frequent dosing. For example, in colistin, it is given in patient with good renal function, but it is not possible to attain a reliably plasma colistin even with daily doses of course at the upper end of approved doses. Loading dose is an initial higher dose of a drug that may be given at the beginning of the course. So while loading dose, because it helps to achieve the therapeutic benefit, the drug must reach the steady state concentration. Important drugs said that because loading dose is vancomycin, oroconazole, ticaprine, colistin, and polymyxin. So that's the benefit of the loading dose. It helps to maintain the efficacy of the antibiotic for a prolonged duration. Loading dose formula is volume of the distribution into target plasma concentration upon bioavailability. So this is the table shows the loading dose, concentration, and the duration of infusion of different antibiotics. Similarly, we have for time dependent antibiotics and constant dependent antibiotics and AUC by MIC dependent antibiotics, the PKPD targets. Now, what does the AST for a multi-drug resistant organism look like? Let's see. For a patient admitted to a hospital with the signs and symptoms of pneumonia, it's first the sample we see the clostridial pneumonia, and there was all the antibiotics were resistant except colistin and cephalosporin ibectam. Lab report indicated that the patient is infected Klebsiella, but the bacteria is sensitive to colistin, cephalosporin ibectam. But taking into consideration the issues related to colistin, such as it is nephrotoxic, also acidotoxic, and poor penetration in lung parenchyma, the patient was started on cephalosporin. So this is how the characteristics of the antibiotics, the being placed in clinical condition needs to be considered while selection of the antibiotics. Thank you.